So a couple months ago, we made a video featuring some social media posts by a heart surgeon talking about cholesterol and cardiovascular disease. At the time, we left them anonymous so that we could focus on the concepts and the science and not have it be an attack on the individual. But the surgeon in question actually happened to see the video, and he reached out and he said it was okay to identify him and he'd actually be happy to come on and chat one-on-one, which I thought was only fair, so we did. So I can now reveal the author of those tweets is cardiothoracic surgeon Dr. Philip Ovadia. He went to medical school at Jefferson Medical College and trained at the University of Medicine and Dentistry of New Jersey and at Tufts. We talked about cholesterol, ApoB, heart disease, diabetes. We agreed on some things and we also disagreed on some things, as you'll see. We had some lively disagreements, but it was always cordial and professional, only way to do it. Now, if you have no idea what ApoB is, I'm going to give you the 30-second primer. If you think you already know all about it, feel free to skip the next 30 seconds and go straight into the convo. So cholesterol is carried in our bloodstream in vehicles called lipoproteins. There are several types. Two that you've heard of are low-density lipoprotein, or LDL, and high-density lipoprotein, or HDL. Now, LDLs carry a protein called ApoB, which is like a tag. And there are some other lipoproteins beyond LDL that also carry that ApoB tag. This family of ApoB-carrying lipoproteins is atherogenic, meaning they raise risk of heart disease if their concentration, their number in the bloodstream is too high. So far, so good. But here's the confusing part. When you go to the doctor and you get your blood work, you normally get your LDL cholesterol, which is the amount of cholesterol being carried inside the LDL lipoproteins. You don't get the actual number of lipoproteins, even though that's what raises risk. So LDL cholesterol is kind of a marker, it's a surrogate of the number of LDL vehicles. It usually correlates, but not always. You can measure your actual number of lipoproteins by measuring the actual ApoB. There's a test called ApoB, but it's not standard. You normally need to go through your cardiologist or something. So this is the foundation of what we talked about. And now here's my conversation with Dr. Ovadia. So I have a number of questions. I'm curious about a number of your views. But before I go into that, I wanted to give you the opportunity, if you have any introductory remarks or any comments you want to make, the floor is yours.
Oh, sure thing. I would just say it's a pleasure to be here with you. You know, I think it's good that we can come together and discuss some of these, I guess we could say controversial, or I'd like to say unsettled, topics. And, I think we have a little bit of a differing background in terms of kind of the clinical versus scientific, view on some of these things. And I think it's going to be, I hope this conversation helps people to understand, what a complex topic lipidology is, first of all, and, how we move from sort of the bench and the science to the clinical practice, and how we can help merge those things together.
For sure. So let's start with what is your primary topic of interest. You talk a lot about metabolic health, but I think I know what you mean by metabolic health. But just to clarify for the audience, because when you say metabolic health, you're not referring to the entire metabolism. You're referring to a very specific set of parameters, to metabolic syndrome and the lack thereof. So can you go over exactly what the parameters are and what you mean by metabolic health?
Yeah, sure thing. So again, I look at it from a pretty clinical definition, I would say, and the five, I would say, well-accepted criteria that we use to define metabolic health, and those are your waist circumference, your blood pressure, your fasting blood glucose, or your hemoglobin A1C, your HDL cholesterol level, and your triglyceride levels. And, the specific parameters for those, I guess, I'll use the ones that I use. or that I think are most commonly used, and therefore I sort of use when I talk about the topic. But in general, we're looking for a waist circumference that's less than 40 inches in men, less than 35 inches in women. We're looking for a blood pressure that's less than 130/85 without the use of blood pressure lowering medications. We're looking for a fasting blood glucose under 100 or a hemoglobin A1C under 5.7, again, without the use of, glucose lowering medications. And then we're looking for HDL cholesterols that are over 40 in men, over 50 in women, and triglyceride levels that are less than 150. And, those 5 criteria, if you have 3 or more of those abnormal, you're diagnosed with the metabolic syndrome. If we know, for instance, here in the United States, based on the 2016 NHANES data, that only 12% of adults were able to meet all 5 criteria of optimal metabolic health.
Got it. So in your experience, most people would have at least one of these things that is not in the optimal range. And if you're working with a patient, so these are basically the 5 tests you would ask for if you want to evaluate kind of their metabolic health, to get a glimpse of that, right?
Yeah, I mean, those are the absolute basics. I would view those as just sort of the screening tool. With my patients, we tend to go deep dive, and we do things like fasting insulin level, and we're looking at lipoprotein insulin resistance scores, which is a algorithmic score based on the distribution of the size of your lipid particles on your NMR panels. I think there are lots of other, things that we use to assess metabolic health ultimately, but those 5 criteria end up just being a useful broad screen, I would say at the sort of population level. And one of the things that, kind of bothers me most about our healthcare system these days is that, most people don't even know those 5 basic numbers. They have the data available to them for the most part because, again, your fasting blood glucose, your HDL, your triglycerides are going to be part of almost any doctor's, lab work panel that's done on a periodic basis. But physicians don't put it together, don't look at it in the framework of 5 criteria. And, it's a warning sign if you have 1 or 2 abnormal, and it's a big red flag if you have 3 of those or more abnormal.
That makes sense. And so I think there's some things that we agree on overall, and then there may be some points of divergence. And I think maybe one question that would be interesting for us to focus on, because I'm pretty sure we're in agreement that metabolism and metabolic health, as you define it, are important criteria, that we clearly have a problem populationally with most of these parameters, if not all, and that it's advantageous medically to work on this and to rectify. Where I think there might be a bit of a divergence is essentially where we featured your content on the video, and it's the view that we should focus on these metabolic parameters, but at the same time neglect LDL cholesterol and ApoB. And that's the question that I was hoping you could elaborate your views on, and that we could maybe try to make sense of. So feel free to correct me if what I said is not how you view it. What is your view of those risk factors in the big picture, together with these other 5 that we listed before?
Yeah. So, in general, what, I see clinically, and I guess what sort of disappoints me at a high level is that we have become so narrowly focused on LDL and ApoB. And, I think we're both in agreement that ApoB is a better marker than LDL. But, quite honestly, I think LDL is a completely useless, lousy marker. ApoB is a better marker, but still suffers from the same problem in that we're only looking at amounts of cholesterol, numbers of particles, amounts of cholesterol in the bloodstream, and we're not looking at the context that those particles are existing in. And so what I see from a clinical standpoint, what led me to, kind of ask these questions is that a lot of the patients that I end up operating on, I end up doing surgery on, have what are considered normal, low, healthy range LDL cholesterol. And again, I'd rather, that we were measuring ApoB, but we don't practically, so, we're stuck with dealing with the LDL cholesterol. And what I see clinically, what's reflected in the literature is that up to half of the patients that come in with a heart attack end up having heart surgery. There are, a couple of different populations that you can look at, but up to half of those patients have, what's considered normal low LDL cholesterol levels. Some of those patients because they're on medications to lower their LDL cholesterol, some of those patients because they just have naturally low LDL cholesterol levels, or, dietary or whatever they're doing that keeps their LDL cholesterol low. And yet they're still ending up on my operating table. They're still ending up in the cardiac catheterization lab. They're still coming in with heart attacks. And so that leads me to say, there must be something else that we should be looking at. And, as I kind of asked, what else should we be looking at? Metabolic health comes up, over and over again. And again, number of ways that you can define metabolic health, whether you define it as the metabolic syndrome, or you specifically measure insulin resistance, or you look at glucose, sensitivity. But, metabolic health consistently comes out in the studies as a bigger risk factor for heart disease than elevated LDL cholesterol when you separate the two, when you isolate them. Combined, you've got big problems if you have both of those issues. But for instance, the Women's Health Initiative study that came out last year, or maybe it's 2 years ago now, I lose track, that showed that isolated elevated LDL cholesterol was about a 1.4x risk factor for heart disease, and insulin resistance, specifically in that study, they used lipoprotein insulin resistance as their measure, was a 10x risk factor for LDL cholesterol. So ultimately, on a clinical level, my biggest issue becomes that the vast majority of physicians look only at LDL cholesterol. They stop at LDL cholesterol and they don't look beyond it. And then they don't look more into the, I guess I'll say the sub, layers of LDL. Why is it that some people with high LDL get heart disease and some people with high LDL don't get heart disease? And why do we see heart disease in people with low LDLs? So why, we need to be looking beyond LDL is my basic messaging there.
Okay, so there was a lot there. I'll try to touch on a key. Let's try to organize it. So the first thing you talked about was the fact that you have a lot of patients that come to you in dire straits and they have normal LDL cholesterol level by the time they get to you. So this is something that we touched on in the video. When you say to a population of lay people, I'm a cardiovascular surgeon or a heart surgeon, and half of my patients have normal LDL cholesterol. The message that people get, 99%, is going to be, oh, so LDL cholesterol is completely irrelevant at face value, right? But as we tried to explain in the video, there are many reasons why that isn't necessarily the case. The information that you're getting as a cross-sectional data set when people come in, there are many reasons that you already touched on one or two of those of why their cholesterol might be low or normal at that point and not reflect the conditions that led up to the event. So you touched on cholesterol-lowering medication. So the cholesterol can be low because they're on drugs, and yet they have plaque burden from decades of having higher cholesterol. So it's not that cholesterol is irrelevant. It's just that it's been artificially lowered and the damage is already there. So now there's residual risk. This is a possibility, and surely it accounts for a fraction. Then there's acute phase reaction, which we covered in the video, right? We both know that people right after having a heart attack, there's all kinds of metabolic changes. And one of them is that lipids come down, they come crashing down. So the fact that you see people with low cholesterol levels at the event is not necessarily reflective of the conditions that led up to the event. We even had the analogy of the car crash in the video. And then on top of that, there is something that is very important to bear in mind, which is that the threshold for plaque accrual is not the same, and this is confusing, understandably, for most of the public, is not the same as the threshold that is defined in medicine as being normal, right? So normally, when we go to the doctor, it's either 100 or 130 that's considered the threshold for normal or high LDL cholesterol. But we know from a large amount of information, including meta-analysis of RCTs, that plaque growth starts at around 60 to 80 milligrams per deciliter of LDL. So it's entirely possible, not everybody, but the people who have perhaps more susceptibility are going to be building plaque in the normal range. This does not mean that LDL cholesterol is useless. And we could talk about whether LDL cholesterol is the agent of risk, and we both know it's not. But it is far from useless. It is a very important alarm indicator. I usually say it's the check engine light on our dashboard. If it comes on, that's not the problem in the engine, but it tells us that there might be a problem in the engine. And so ignoring LDL cholesterol, which is what a lot of people are going to get from your content because they don't have the necessary training, they're going to look at that, and at face value, they're going to think, oh, so if I'm walking around with an LDL cholesterol of 200, it's irrelevant as long as I'm not diabetic and insulin resistant and these things. And that's a misunderstanding, because their ApoB is likely very high, and it's going to mediate risk in addition to the risk mediated by the metabolic conditions. I don't want to hog the time, so I'll let you go, and then we'll try to touch on the other topics. Go ahead.
Yeah. So, what I would say about that, and again, a lot to get into, is that the messaging that's out there now, what people are hearing is that if I lower my LDL cholesterol, I don't have to worry about anything else. And that's the simple reality. Patients are, I see them all the time, and they say, I don't understand. I've been taking my statin medication for 15 years, and I'm here getting heart surgery. That is kind of the problem that I'm trying to talk about. And I never say that LDL cholesterol is completely meaningless. I just think it's a lousy check engine light, to use your analogy. Because if your check engine light comes on and half the time it means you have a problem, but half the time it doesn't mean you have a problem, then the check engine light becomes pretty useless. And again, we see plenty of situations where the check engine light has come on. People have high LDL cholesterol, yet they never end up with heart disease. There is no problem with the engine. We do the CAC scan. They have no plaque. There's no issue there. And then we see lots of times where the check engine light never came on. Their LDL cholesterol has been low, or they've been managing their LDL cholesterol and keeping it low, and yet they end up with the heart disease, and they end up, on my table or someone else's table. And so that is why I think we have been doing a big disservice for many, many years now with our singular focus on LDL cholesterol. And, understand that you and I, we know that you can't stop at LDL cholesterol. We know the picture is a lot more complex than that. And, whether it's metabolic health, whether it's ApoB, whether it's Lp(a), whether it's, your NMR panel, we just know that you shouldn't be stopping at LDL cholesterol. But the vast majority of physicians who are prescribing statin medications, they stop at LDL cholesterol, and they don't even think about it. They go by the guidelines that say LDL cholesterol above this level, prescribe the statin, and that's the solution for the problem. And that is doing a big disservice to our population, because lowering LDL cholesterol by itself, whether you want to do it with medication, you want to do it with dietary intervention, is not enough, clearly. And there are plenty of people, like I said, who are lowering their LDL cholesterol, following the guidelines, and yet they're still ending up with the disease that we are supposedly preventing or trying to prevent with those guidelines. And that's where I have the problem. And that's where metabolic health comes in. But, again, I'll just stop there so we can explore that further or branch out from there.
Okay, I'll comment on a couple of things. So one thing you brought up was that some people have high LDL cholesterol and yet have no lesions or have no events. Well, that has no contradiction with LDL cholesterol being a risk factor, right? That's just the definition of a risk factor, is not something that's going to cause the disease in every single individual. If we have a population of smokers, more people are going to have lung cancer. If I find a bunch of people who smoke and don't get lung cancer, that doesn't mean that smoking is not doing anything. So finding some people who have high LDL cholesterol and get away with it because they don't have the susceptibility is not how we determine if something is a risk factor. We determine if something is a risk factor by looking at reasonably matched populations and seeing if there's more events and higher risk in the population with a higher magnitude of the risk factor, right? So the reason I'm harping on this is these are things that are extremely confusing for a lay audience. And when we say things like, oh, but I know people who have high LDL cholesterol and yet they don't have the disease, for most people, this is incredibly confusing. They will jump to the conclusion that, oh, so LDL means nothing, when it's so simple to see that that's not the case with the tobacco example. Okay. To the extent that doctors, I don't know any doctor that focuses only on LDL cholesterol, but I'm not doubting that they're out there, and I'm not doubting that you know them. If someone is only focusing on LDL cholesterol and doesn't care about diabetes and blood pressure and residual risk, which is an established, well-described phenomenon, once you lower your LDL cholesterol, there's residual risk present. So to the extent that people are focusing exclusive on LDL cholesterol, I'm completely on board. Let's go beyond that. But we don't have to tell people that LDL cholesterol is meaningless, because it isn't. It is a fundamental indicator. If the light is on and 50% of the time we have a problem in the engine, yes, it's a little annoying that half the time we look in the engine, there isn't a problem. But if we just ignore the light, half the time the engine blows up after a few years, right? It's completely reckless. We don't want to do that. At least we want to investigate further and measure the ApoB. If that's the call, I'm 100% on board. So yeah, residual risk. Yeah, I mean, I'm completely on board that LDL cholesterol is not the full picture. It's not even the agent of risk. ApoB is one of the crucial causal risk factor. There is no plaque without ApoB carrying lipoproteins getting into the artery wall. And ApoB has been demonstrated, ad nauseum to be a causal risk factor. So to the extent that we want to alert people that there are other things, that it's not 100% LDL cholesterol, I'm 100% with you. My appeal, my request is just that we not shine a spotlight on other things at the expense of people neglecting ApoB or any indicators thereof. That's incredibly dangerous.
Yeah. So, but here's the problem with that, in that the things that we have done on a societal level, because of this focus on LDL cholesterol, and these are things like the low-fat diet, do carry harm with them. And these medications, statins and every other medication has potential harms to it. And we can't ignore those facts. So again, the problem becomes when we just make these binary decisions. LDL cholesterol high, need to do something about it. LDL cholesterol low, don't need to do something about it. When we make these binary decisions, there are consequences of those decisions. And the consequences of those decisions, I would argue at this point, may have been worse than the original problem. When we decided to implement a low-fat dietary strategy, here in the United States in the late 1970s and early 1980s, we then set off a true epidemic of obesity and type 2 diabetes and hypertension, which are major risk factors for heart disease. So the outcome has been that we really haven't made any meaningful impact in heart disease, with the now 30-year plus focus, I'll say, on LDL cholesterol. So we need to step back and say, what are we doing? And again, these are population level risk factors that we're then trying to apply to individuals indiscriminately. And that is where I have the problem. And so, again, when I go back to the check engine light, we have to factor into the equation that if we're constantly responding to that check engine light, what are the consequences of our response to that light? And maybe they're worse than what we were trying to originally fix in the first place.
Okay, well, leaving aside the low-fat diet, which I think we can clearly find conclusive evidence that nobody did, populationally, nobody went on the low-fat diet.
No, that's not true at all. The percentage of fat in the diet clearly dropped in line with the guidelines. The percentage of saturated fat clearly dropped in line with the guidelines. So we can't say that people didn't do a low-fat diet. What we can say is that a low-fat diet ended up pushing us towards a high carbohydrate diet, a highly processed food diet, and that has clearly led us to a situation where we now have rampant epidemic obesity and type 2 diabetes rates that are clearly worsening the heart disease problem.
So exactly as you said, the percentage of fat came down. The total calories went up. The amount of fat stayed approximately constant. So the percentage of fat was reduced. So it appears that people are eating less fat. The amount of fat was approximately constant. Nobody went on a low-fat diet populationally. Now, if you want to argue that this is a point against a low-fat diet because the recommendations were to eat low-fat and nobody did, I don't disagree with that. It's not a popular diet. What we can't say is that we tried the experiment at a country level and the low-fat diet caused all these things because we don't have the stimulus there in place. But okay, we can leave the low-fat aspect to the side. I think there's more important points that you made. You said that we've made no impact on heart disease. If we look at, I was looking at that recently, and if you have different stats on that, I'm happy to look at them. But the cardiovascular mortality per capita, not total, has come down sharply since the 50s, all the way to now. It has come down by more than half. It's been cut. So it's not that we've done nothing. Clearly, something has changed. This is, now, let's make a caveat here. This is ecological data. It's one of the weakest forms of data, right? So there's a 50,000 confounders. We can't attribute this to an effect of the diet or to an effect of statins because so many things changed, we don't know what it was. But cardiovascular mortality has come down abruptly over the last 50 years or 70 years. And the last thing, I'll just touch on one last thing. You said that statins may cause harm. Yeah, all medication, you know this as well as or better than I do. All medication has side effects. The way we decide if it's appropriate to give it to someone is risk-benefit analysis. So if the benefit outweighs the harm or the risk, then it's appropriate to give. Well, this is information that we have from large meta-analysis of randomized controlled trials that the benefit is substantial if the person is at higher risk, and that the risks, the benefit largely outweighs the risk in all cases, even in people at high risk of diabetes, for example. This has been all directly looked at with the Jupiter analysis and others, specifically looking at the risk factors and whether it's worth it. And even in people who are the categories at the highest risk, it was still worth it. So we have to be very careful because, again, there is this propensity for misunderstandings on the internet and this type of messaging, people will immediately jump to the conclusion that statins are harmful and that nobody should be on them. Extremely dangerous. And we have evidence that when this type of discussion hits like for example, if on TV people are talking about the risk of statins, immediately the people start taking less of these drugs, and we see an uptick of events a few years later. So we just have to be extremely careful when we talk about cholesterol and metabolic disease and statins, and be very cautious with how we communicate to the public. Avoid oversimplifying things and kind of the blanket statements that lead to misunderstandings. Go ahead.
Yeah, I would exactly agree with you that we need to avoid oversimplifying this issue, and that's exactly what we have done. Because again, I go back to what I see all around us and the messaging both to physicians and to the public is that heart disease is cholesterol and cholesterol only, and that we need to be lowering everyone's cholesterol as low as possible, and the statins weren't enough. So now we have to start giving everyone PCSK9 inhibitors and, get cholesterol levels down to exceedingly low levels in order to prevent heart disease. And the reason that we have to do that is because we haven't been able to prevent heart disease effectively by lowering LDL cholesterol levels. So we get into this circular, argument and the simplistic messaging around heart disease. And exactly like you said, this is not a simple issue, and we can't be putting out this simple messaging that, statins are good for everyone and they should be in the water supply, which is things I have heard from public health officials. And you're right. We also shouldn't be saying that no one should be taking statins. And I have never said that. And, I certainly try and get the nuance, into the discussion as much as possible when I'm talking about these things. But I do have a big problem with the singular focus. And, it is a singular focus. I can tell you that physicians largely, I don't want to, misstate this. I don't want to say this in a way that, mischaracterizes physicians. But the forcing physicians with guidelines that are very narrow and only look at an LDL cholesterol level is the wrong approach. And it's getting the wrong people. The therapies are being directed at a lot of the wrong people, is I guess how I would say it best. And we can look at things like number needed to treat for benefit with statin therapy in primary prevention. And we see that is, somewhere between 80 and 120, depending on, which studies you're looking at. And I would say that is not good enough, because treating 80 people unnecessarily to benefit one person should not be something that we as physicians should be accepting. I want to know, how do we better figure out this problem so that I can give those medications to the people who are actually going to benefit from it?
Let me go on the record and say that I also don't believe that statins should be in the drinking water. It's crucial to, like I said, risk-benefit analysis, right? You don't give it to anybody indiscriminately. You give it to people who need it, who is going to benefit. Now, one thing you said I strongly disagree with. You said that we now have to give people PCSK9 inhibitors because statins didn't work or because it didn't lower risk. It's the opposite, right? Statins demonstrated in meta-analysis of RCTs lowered risk. They didn't bring it to zero. So we have residual risk. PCSK9 inhibitors, when added to statins, again, meta-analyzed in large RCTs, bring the risk down further. So that is why they are recommended in the right situation. With regards to the singular focus, again, I'm not doubting that this happens, but I mean, when we look at recommendations by professional scientific organizations, even the American Heart Association, and I'm no fanboy, certainly have their issues. but even their public facing message is the Life Simple 7, I think they call it. It has like 7 risk factors. Only one is cholesterol. It has diabetes in there. It has healthy body weight in there. It has blood pressure in there. It has exercise. It even has HDL cholesterol in there. So I'm just not seeing this picture of nobody caring about anything other than cholesterol. And I mean, we could jump on the American Heart Association page right now and see what we see, if it's all about cholesterol or not. I don't know how meaningful that would be, but I have not seen it. And the guidelines extensively talk about managing blood pressure, about managing diabetes, about healthy body weight. So, I mean, I don't really see the singular focus that you are talking about, but we can definitely agree. And I just want to ask you this very straightforwardly. So if we both agree that the singular focus is not adequate, wherever it may be, so are we in agreement then that the approach to cardiovascular disease prevention or management should involve both attacking metabolic health as you define it, diabetes, blood pressure, all these factors, and bringing ApoB down to a healthy range?
No, the argument that I would have with that is that, there is clearly a population, and, maybe it's small, maybe it's big, we don't really know is the honest answer, but there is clearly a population that high ApoB, high LDL cholesterol does not end up being a predictor of heart disease, does not end up being a risk factor for heart disease. There are people with high ApoBs, high LDL cholesterols who do not develop heart disease. So I would like to see us figure out why that is. I would like to see research into why that is and how can we better identify who those people are. And it seems to be, and again, I fully admit, not definitive data. We don't have the studies because no one's ever looked at it. But if you are metabolically healthy and, if your LDL particles are large and fluffy, not small and dense, pattern A, again, however you want to measure it, if you have a low LPIR score, all these things are sort of reflecting a lot of things, the same thing in a lot of ways, that there is not risk associated with ApoB, LDL in that context. And so we should be looking at the nuance of who is truly at risk from their elevated ApoB and LDL cholesterol, and who is not at risk from their elevated ApoB and their LDL cholesterol.
What's the population exactly that you think, or that you've seen evidence for, that have high ApoB population, right? We're not talking, let's make it very clear, we're not talking about individuals who have an ApoB and yet have no heart disease, because that's not a mystery, right? That applies to all risk factors. So you're saying that there's a defined population that have high ApoB and have been demonstrated to not have higher risk?
No, what I'm saying is we haven't looked at that. We see plenty of individuals, but to my knowledge, there aren't any studies that have ever asked that question and looked at why, who are the people with high ApoB that get heart disease and who are the people with high ApoB that do not get heart disease, and what are the factors that go into that. And I would love to see that study at a population level. My inclination, based on what I've seen clinically and the individuals that I've worked with and the discussions we've had with other clinicians around this, is that it seems to be that if you are metabolically healthy, if you are not insulin resistant, if your particle, distribution, your particle size distribution is towards the large LDL, that you are not at risk from an increased LDL and or ApoB cholesterol. But again, we need to figure that out. I guess on the population level, we need the studies, and those questions are not being asked by the organizations, by the American Heart Association, by the scientists that are doing lipidology research.
So we can go through the evidence specifically on what you're saying. People with high ApoB and with or without metabolic impairments. There's quite a bit. So scientists have looked at it to some extent, at least. Yeah, there's still work to do, but we have quite a bit of information. But there's a broader issue here that I don't understand. You said that it's not a defined population, that we don't know what the factors are. What you're saying is that because some people have high ApoB and yet don't go on to develop heart disease, that we should not tell people to normalize their ApoB. This caveat applies to all risk factors, Philip. It applies to smoking. Lots of people, most people who smoke don't go on to get lung cancer, and we don't understand exactly what the factors are that determine susceptibility. But we still tell people not to smoke as a whole, precisely because we don't know who is susceptible. So why in your mind do we not tell people, do we let people walk around with ApoB and we let the ones that are susceptible be at higher risk and have cardiovascular disease, have heart attacks, have strokes, and die of coronary heart disease, and yet we tell people to avoid the other risk factors? What's the difference?
Again, the difference is the consequence that comes from what you need to do to lower ApoB or LDL cholesterol. And if you're telling people to avoid saturated fat in their diets, which again is only been shown to be beneficial in epidemiologic level data that may have, that does have lots of problems with it, and you're putting people on these medications for lifelong. We are starting 20-year-olds, we are starting teenagers on statin medications, and we do not know the implications of that. These medications have been studied for 5-10-year studies. No one has looked at them for 40, 50, 60-year studies to know what the effects of being on these medications long-term might be. So again, like you said, risk benefit, and we do not have the risk benefit discussion on a clinical level. I can tell you that it does not occur. It is very rare that patients get, what I would consider an adequate risk-benefit equation on lowering their ApoB, LDL, whichever marker we're going to look at. And I do want to say, we do also need to recognize that you and I, agree that ApoB is a much better marker than LDL cholesterol. But the American Heart Association guidelines are LDL cholesterol, as are all the other major organizations. ApoB is not utilized in common clinical practice. Those of us who are lipidologists, or those of us that are interested in the topic, we talk about ApoB, and we know that it's a better marker than LDL. But the simple reality is for the vast majority of the population, this decision is being made on LDL cholesterol only.
And there is a push by some leading experts to get ApoB more into a reality. But I mean, I'm asking you if you think ApoB should be lowered, and you're telling me that it shouldn't. So I'm a little on one hand.
No, I didn't say it shouldn't. I said it shouldn't be lowered for everyone, or it's not necessary to lower it for everyone.
Who do you lower it for if you don't understand exactly who's susceptible and who isn't?
So again, I think we do have pretty good understanding of who is susceptible and who isn't. We just don't have that in guideline level recommendations. And people who are metabolically healthy, people who have no evidence of heart disease at the current time, and again, I think that's another underutilized resource, the coronary artery calcium scan, to know who has it and who doesn't it. I don't see any evidence that someone with that scenario should be lowering their ApoB.
Okay, so we are agreeing for now that everybody who is not metabolically healthy should lower their ApoB, and those who are metabolically healthy, you are saying they shouldn't. We're going to touch on the data, but for now, we're agreeing that the metabolically unhealthy should lower their ApoB, according to what you just said.
Yes, but I would argue that they would get more bang for their buck in getting metabolically healthy than lowering your ApoB. And this is where the other conflict comes into play, that sometimes the interventions that make people metabolically healthy, specifically low carbohydrate diets, will raise ApoB, will raise LDL. And that's not a universal occurrence. It's in some people. But that's where we get into this conflicting situation where it becomes problematic that we say that someone has done an intervention, they have improved their metabolic health, they have improved all of these other markers, but that intervention can't be good for them because it has raised their ApoB or their LDL cholesterol.
So low carb diets don't raise ApoB. It's the quality of the fats that raises ApoB. I mean, that we know from metabolic ward isocaloric experiments.
The quality that you and I know, but the general message is that low carb diets raise your cholesterol level.
Okay, we can agree that that's an incorrect, and I've made several videos explaining that low carb diets don't necessarily, low carb diets can improve your ApoB. It depends on the quality of the fats that you're eating. And you touched briefly on saturated fat, and you said that the evidence for the benefit of lowering saturated fat is all from epidemiology. Let me just correct that. That is factually incorrect. We have meta-analyses of 15 or 16 randomized controlled trials looking at the substitution, the replacement of saturated fat and substitution with other foods, and they find a statistically significant reduction in major adverse cardiovascular events. So,
but we also have a number of randomized controlled trials that point to it, that show exactly the opposite. You know, we have the Minnesota coronary data, we have the Sydney heart data, both of which showed interventions to substitute, you know, to lower saturated fat in the diet did not lead to a lowering of cardiovascular mortality.
Those two are included in the meta-analysis. Sydney is included in these meta-analyses that I'm talking about. Minnesota, as we both know, was truncated, was an aborted trial about after 13 months. So it's not a test of the hypothesis, regardless of the substitutions. They found no statistical significance between the two groups. As expected from a trial that lasted 13 months, it was projected to last 3.6 years, if I'm not mistaken, but the conditions nationwide changed. So they had to abort the trial, and the average follow-up was 13 months, and they found no statistical difference. But Sydney is included in the meta-analyses that I just cited. So it's subsumed by that. So what I'm saying is the meta-analysis of randomized controlled trials has evaluated the trials that you're talking about, and the net effect of looking at the body of literature is a benefit, even including Sydney. So how do you wrap your head around that level of evidence, and how is that not indicative of a benefit of lowering saturated fat? Particularly, we have to be careful if we replace it with more health-promoting foods like polyunsaturated fats or whole carbohydrates, which is what has been found to reduce risk, or mono.
So just to be, I just want to make sure that we're kind of on the same terms and discussing the same things. When you are talking about substituting with polyunsaturated fats, you were talking about, you know, vegetable and seed oils, or are we talking olive oil and, you know, coconut?
Olive oil will be mostly monounsaturated. Sources of polyunsaturated fat range from flax seeds to chia seeds to fatty fish to vegetable oils that are not olive oil, so polyunsaturated fats. But we're on a huge tangent here.
Yeah.
But my point is, if we have a meta-analysis of 15 randomized controlled trials that includes Sydney, that shows overall a benefit of lowering saturated fat, what evidence do you have that supersedes that?
We have other meta-analyses that have not shown the same thing. And, you know, the work that's been done by David Diamond in this area, contradicts those. We have conflicting meta-analyses in these, because there are meta-analyses that show that lowering saturated fat does not have any impact on cardiovascular mortality. And then again, I go back to what are the consequences of lowering saturated fat in the diet, and the practical reality of lowering saturated fat means that you are eating more processed food, and eating more processed food is clearly not, is clearly harmful to people's overall health.
why would lowering saturated fat equal eating more processed food?
Because the reality is when you remove the food sources of saturated fat, you have to eat something else. And for the vast majority of people, that becomes processed food.
Oh, I see. You're not saying that we have to. You're saying that the general trend in the population is to replace saturated fats with junk food, with
yes,
processed foods.
I'm not saying you have to. I'm just saying that's the practical outcome of it.
I completely agree that that's usually what we see in the West, in the United States. But so our job is to explain to people that they can replace some of the saturated fat. I'm not saying that saturated fat needs to be zero. Or the ranges have been pretty well defined in these metas of RCTs. But we can explain to people that it can be replaced with whole foods that are lower in saturated fat and higher in other forms of fat or protein or carbohydrate. So there is no necessity of replacing with junk food. That's not, yes, that wouldn't be ideal. I agree with you. Oh, you just wanted to briefly touch on, you said that some of the meta-analyses show no effect on mortality. Yeah, the meta-analysis that I cited, the largest meta-analysis that has been done to date from the Cochrane that came out in 2020, it doesn't show a statistically significant reduction in mortality either. What I said was it lowers major events, adverse cardiovascular events, so MACE, right, the composite. Mortality doesn't reach significance. Yeah. We can talk about why. There are technical reasons.
Well, but so I think the other point that needs to be brought into that discussion then is that even if the studies that show lowering of cardiovascular events, if that doesn't translate to a reduction in mortality, all-cause mortality, then again, is that a net benefit to on the population level? Because this is another problem that we have in that we don't have the all-cause mortality outcome studies, and that yes, it's great if you avoid a heart attack, but if it ends up giving you some other problem that's going to lower your life, limit your life, you haven't made any net benefit to people. We have to realize from a clinical standpoint that people don't really care what they die from. They care that they die or don't die. And so we have to be careful about, again, a narrow focus on preventing one problem that can inadvertently lead to us having a much worse problem. And that's where I go back to the interventions that have been done on a population level because of this focus on LDL cholesterol has led us down a path that is associated with, not causative. I agree. We can't say it's causative, but is associated with much worse population level health.
So coming back to this mortality issue, and again, we're probably not going to have time, but there are technical reasons why the mortality differences are not statistically significant. But an intervention that shows a reduction in cardiovascular events, that's less heart attacks, strokes, things like that, and where there's no difference in all-cause mortality, is that something desirable or is it not? I mean, I'm pretty sure that we both agree that that's something that is incredibly desirable. If it lowers heart attacks, lowers strokes, lowers revascularization events, and we still die on the same day, isn't that an incredibly beneficial intervention, even if we don't go into the technicalities of why we couldn't see a benefit in mortality?
I would argue that it may not be. And again, because we are not looking at the consequences, of that action. And if the consequence of that action is that it did something else that caused us to die on the same day, then, that is not a net benefit necessarily. So it may be, I'm not saying it isn't. I'm not saying we should be ignoring MACE and, we shouldn't be looking at these studies, but we do have to keep the big picture in mind that while heart disease is the number one killer in the United States and worldwide, it is not the only killer. And, we have to be careful about recommending actions that are going to have other consequences that we may not have fully explored.
So I'll give you another. Sorry, go ahead.
Yep. Go ahead.
I'll give you another example that does lower ApoB and does lower MACE and does lower all-cause mortality. Statins do, meta-analyzed, if the study is large enough to be powered for all-cause mortality. And having lower ApoB per se, genetically determined. So the totality of the evidence is telling us that having lower ApoB, whether it's drug induced with statins or through other means, for example, if you're born with it, but probably through other interventions, lowers all-cause mortality as well. So is that not a reason, by the same logic, to favor lowering ApoB?
So what are the statin studies that have shown all-cause mortality benefit?
Several. The very first trial of statins, 4S, showed a reduction on all-cause mortality. Several after that and then
no. We have to be very careful because that data has never been validated in another independent study. Data has not been released for again, they have been very careful about not releasing the data for public review from 4S. And there is a lot of problematic things that we see when you really look at the 4S trial and you look at all the subsequent trials that have not been able to demonstrate an all-cause mortality benefit.
Several have. Several after 4S have. I can send you all of that tomorrow. If I can look it up now, but it might bog this down too much. But I can.
I don't. Yeah, I agree. I don't think
I can tell you with 100% certainty, that trials after 4S have shown lower all-cause mortality if they're powered for it, and with 100% certainty, meta-analyses grouping and randomized controlled trials have shown lower all-cause mortality. So if you have the power to detect it, you see it. Even if no single randomized controlled trial had shown it, but the meta does, that would still be pretty compelling that there is an effect. It's just not detectable. But we have several individual metas. So
again, we have to be careful there because we have to realize that meta-analyses, are selective. They pick which studies get included and which don't. They have exclusion criteria, and it's not clear. And again, this is, we started talking about, one of the issues is translating population level science to individual, clinical cases. And, I am a clinician first and foremost. I see individuals, and I just realize, I just see that there are a lot of problems when you start translating these population level studies to individuals. And that is again, you said it, I said it, we both agree, we need to be having risk benefit discussions at the individual level. And that just is not occurring on the, for the most part. And the guidelines also don't really allow for those risk benefit equations. And quite frankly, most physicians are not prepared to have those discussions.
We can agree that risk benefit is crucial. I don't think there's a controversy there. I don't want to keep you too long. So maybe the last 5 or 10 minutes, we can touch on the idea of the context of metabolic health, because I think this is a very common question. A lot of people ask me this. And so I think I agree this is a very important, interesting question. And I've looked over the years for information on this. So just a few things that I found, and you might be familiar with this as much or more than I am. So they've done subgroup analysis in a lot of these RCTs, specifically looking at these parameters that you laid out right at the beginning of our conversation. So people with and without diabetes, in both cases, ApoB still raises risk. With and without high blood pressure, in both cases, ApoB still raises risk. With high or normal fasting blood glucose, in both cases, we can still see, so even people with normal glucose, we still see plaque accrual, we still see events, and it's proportional to LDL cholesterol level. Any BMI, obese, normal weight, overweight, all three categories, ApoB still raises risk. Normal levels of inflammation or high levels of inflammation, presence or absence of metabolic syndrome. And just to give you one example of one cohort, PESA, which I'm sure you're familiar with, asked this exact question. If we look at a population where these risk factors are in check, people are not obese, people don't smoke, people don't have diabetes, people don't have HDL is good, trigs are good. Do they still have heart disease? They look specifically at plaque. So they can still have extensive plaque, and there was in proportion to LDL cholesterol. So I'm not saying that this has exhausted all the possibilities, but everything I've investigated consistently points to the idea that even in the situation where these risk factors are not there, ApoB still mediates risk. So it's forming a very strong picture that ApoB is an independent risk factor. That means that we should take care of all these different risk factors at the same time as we take care of ApoB. Go ahead.
So, I come back to, what is and I don't want to get too nuanced into these studies, but what is the magnitude of that risk? When we, if we're selecting out, all of those populations, what magnitude of risk are we left with? The data that I have seen is that magnitude of risk is very low. And again, what are the consequences of then these interventions to lower, the ApoB? And that, I think, is where we start to get into the problem. And again, at a population level in scientific studies, in these studies at a population level, how does that translate to the individuals that I then see every day? And yes, there may be some increase in risk, but it's not a large magnitude. It's not 100% certainly. And so, what are the consequences going to be of these interventions to lower the ApoB? And that's, I think, where the, where the disagreement comes from.
I can answer that with some precision, because in the vast majority of these comparisons, the relative risk reduction was identical with and without the risk factor. Now, the absolute risk reduction is going to be larger, of course, because you're compounding risk factors. So, of course, if you have 3 risk factors, you're at higher risk, but the relative risk reduction is identical. So we're looking at the same, somebody without all of these metabolic components. We're still looking at the same magnitude of reduction of risk as the general population in terms of relative risk reduction. And that we know exactly what that is. That is about 22 to 25% lower risk per 38 points reduced in LDL cholesterol. In the short time window of the trials, right, 4 to 5 years. If you look at a longer time window given by the genetics, then we're looking potentially at a 2-fold reduction or a 50% reduction. So we cut the risk in half for each 38 points of LDL cholesterol that's reduced. So the magnitude is potentially enormous. And we could go do math on the potential benefit for somebody who with high LDL cholesterol who doesn't have any of these risk factors. And we're talking at a several-fold reduction of risk. Very easy to do that math. So again, my point, and maybe my take-home message, I'm 100% with you that all of these things matter: diabetes, blood pressure, to the extent that we're shining a light on them and raising awareness that people should look at this more, both the public and doctors. I'm 100% with you. Let's join voices and do this. But the importance of ApoB as an independent risk factor, as a causal risk factor, and the magnitude of the effect is impossible to wave away. It is a crucial factor. And if we tell people to focus on this at the expense of ApoB, and we have its imperfect but useful marker, LDL cholesterol, we are potentially causing enormous harm. So that's my take-home message.
Yeah, and I would say, again, I think we agree upon more than we disagree upon. And, I would largely say the same, but my takeaway message would be that I think that the amount of energy, let's say, that we have put towards the cholesterol lowering question has distracted from bigger efforts that could be made to impact heart disease specifically, but overall health generally, in a more effective manner. And again, when what I see at the clinical level is that we have a lot of people who are only been told that they need to lower their LDL cholesterol, that, take the medications, lower your LDL cholesterol, and they are still ending up with a lot of heart disease, and that we need to do a better job of getting exactly that message out, that it's not only about LDL cholesterol, that we need to be focused on metabolic health. We need to be focused on these other things. And we also need to recognize that there are people who are not at risk despite having elevated LDL cholesterol or ApoB. And I would like to be able to better figure out who that is. And I would, I think we need to have the latitude to, basically admit that. And again, that doesn't mean that no one benefits from lowering it. It just means that everyone doesn't benefit from lowering it. And so we shouldn't have these guidelines that basically say you need to lower it in everyone.
Okay, I go back to, if we don't know who the population is that's going to benefit, it's just like tobacco. We have to tell everybody to avoid the risk factor. Otherwise, we're exposing the ones that are susceptible. But I completely agree with you, although I don't understand that reasoning of not seeing ApoB just like the other risk factors. Tell everybody to avoid it so that we protect the people that are susceptible, since we can't distinguish who those people are. Same logic as tobacco, same logic as diabetes or obesity. But I completely agree with you that we should have this broader view. And I think I think I'm trying to do that. I've made videos about diabetes. I've made videos about blood pressure and ways that people can improve these metrics. So I completely agree with that. Let's have a broader view and help people improve their health in general. I'll let you, any final comments that you have before we kind of sign off?
No, I think this has been a good discussion. I hope people have found it useful. I hope people take away from it that, this is a very nuanced topic. This is not a simple topic. And, we're honestly, we're not going to solve this, on podcasts and on discussions like this. But I hope that it causes people to think about these issues, to question these issues. I hope it causes people to ask these questions to their physicians, so that we can, get physicians, quite honestly, thinking about this more, and so that we can move forward and we can figure out, yes, these are risk factors, but, who is truly going to benefit from these interventions, who is not going to benefit from these interventions, and admitting that there is harm associated with these interventions, so that we need to be able to better target it to the people that are truly going to benefit from it.
Well, I completely agree with asking questions. Healthy skepticism is like the middle name of my channel. So everything I try to do is about healthy skepticism, about searching for the evidence, about listening to what people are saying, and then asking for the evidence for those claims, and looking at evidence, not reflexively dismissing views and not reflexively accepting them either. So I really want to thank you for coming on, for having a really enjoyable discussion. I think we discussed a lot of interesting topics. It was good. It was lively. It was respectful. I loved it. Thank you so much for your time and for coming on.
Yeah, and I hope we can have future conversations to continue the discussion.
Absolutely. Take care, Philip.
Thanks, Gil.